What we start with is a foundation, and then we adapt the care to the individual as appropriate. The medical record is always going to dictate what we do, right? Because we don't invent the symptoms, we don't invent the findings. Our job is to test and interpret, and then use our clinical knowledge to take that interpretation and effectively manage that patient's care and therefore their outcome.
Hello and welcome to the Compliance Corner with Dr. John Runpakis and Dr. Chris Wolf. What we wanted to do today, this is on iCode Media, and you'll see it on the same feed, and our goal is to monthly give you an update of kind of timely things that we're seeing from a compliance standpoint, from a billing and coding standpoint, from a practice process standpoint, so that you can be prepared, you can take actionable steps to protect your practice, protect your documentation, and continue to deliver the care that you want to deliver to your patients in the way that you believe is in their best interest. And then we'll give you some other practical tips. If you're a practice performance partner user and member, we'll show you exactly where to look, or if you're not, where you can get access to some of those resources. So Dr. John Runpakis, thanks for joining me today. We're going to talk about glaucoma and some of the timely things that you're seeing from a compliance standpoint, where OIG and other entities might be looking into our glaucoma practices. And so that's what I want to discuss today.
That's great, Chris. I really appreciate being part of this. I'm excited about sharing the information with everybody out there. I think everybody knows that, with Medicare and the federal government right now, the primary focus has been on fraud, waste, and abuse, irrespective of where it's coming from, at the practitioner level, at the mid-tier level, at the hospital level. That's their overarching focus right now, is trying to recover some cost savings from healthcare providers and healthcare organizations. And one of the primary things that raises its head with the care of glaucoma is that in an ophthalmic-based practice, of course, it generally requires a fair amount of testing and follow-up care, both for office visits and follow-up testing, and that those tests and follow-up frequency are often scrutinized by the carriers. And we're starting to see now quite an increase in that attention that they're putting on us to get cost recovery.
How do you view that? So, because as I read some of these things, I'm looking at and you hear me talk about developing protocols all the time within your existing practice. But you'll always also hear me say, listen, we might look to a standard like our clinical practice guidelines or our preferred practice patterns. And then we might incorporate that standard into our practice to say, this is our standard for a patient who has mild, moderate, severe glaucoma. It gives us guidance. But I say, then you have to individualize that for the patient. So how do you view those that hierarchy of protocols as being protective, as being destructive? How do we take that information and say, this is a way to do it in a way that allows me to, one, protect the patient from not doing testing as often as recommended, but two, protect myself from maybe malpractice lawsuits because I was afraid of ordering a field because maybe I ordered it too many times, or I'm going to be scrutinized.
Sure.
Versus delivering the care for that individual patient that they need.
Well, I think you hit on a great point. So, part of PPP's mantra that we think about and stand behind all the time is keeping a practice safe primarily and profitable as well. And there are ways to do that you can absolutely 100% eliminate risk without necessarily putting at risk your profitability within providing the highest level of care. So you mentioned two sources or authoritative bodies that we really rely upon: the American Academy of Ophthalmology's preferred practice patterns and the American Optometric Association's clinical practice guidelines. Both of them are excellent resources for an individual to go back and re-examine how they're applying their glaucoma care protocol against what the clinical standard is by these two bodies is. So let's talk about safety first. If I'm a practitioner and I get questioned on something, the very first thing I'm going to want to go to is an authoritative resource that says, look, this body who governs all of the care that's provided says this is the minimum clinical standard that you should do, right? And I think that's where we need to stand, whether it's with the Academy's preferred practice patterns or the AOA's clinical practice guidelines. Both are great. Both are a little bit different, so I think you could go to either one of them and use the one that maybe blends with how you like to run your practice the best. So that needs to be our foundation from which we build. So if we say, look, you've got a patient who's got moderate, primary open-angle glaucoma, they've got it bilaterally, or even if it's unilateral, you're going to treat to the level of the worst eye, of course. And it says that you are supposed to do 2 OCTs in a given year, alternating with a visual field, right? So if that's what the clinical protocol is, you need to figure out a way to adapt that into your individual protocols within your office. And you're absolutely 100% spot on when you say that we have to individualize the care. I can't take everybody that has the ICD-10 code H40.1132 and test everybody the same, follow up everybody at the same intervals across my entire practice. That's not individualized care. I have to start with the clinical protocol that the bodies provide to us. I then have to adapt it using that patient's individual, history, their systemic history, their, familial tendencies from their genetics and things like that, and then build the care protocol based upon them. If I start that way and I now individualize the care, and I'm really good at doing making sure that the medical record reflects my thoughts, my patterns, my logic for doing this, that's where if somebody comes to audit me because I did 3 visual fields in a given year or 3 OCTs, I can now go back to them and say, this is where I started, this is where the patient was, this is the clinical sign I got, this is my medical decision making process, and this is where I ended up clinically. In my experience in audit defense and things like that, or with carriers demanding payment back or accusing us of over-testing or whatever, I always go back to where did you start and what's in your record that shows me why you departed from the clinical standard that is. And if you've got that recorded well, those practices do very well in an audit, because carriers don't dictate medical care. They do set guidelines. And fortunately for us, and almost all types of care that we give, but particularly glaucoma, many of the carriers rely on the Academy's preferred practice patterns. I'd like to see the AOA get more involved in that, but really right now it's mostly the Academy that they rely upon. So if I'm using that same standard as my foundation, I'm starting in a good spot. I think what we have to fight in most practices, though, is complacency, right? People get used to just doing something the same way for everybody.
If you're ready to stop feeling overwhelmed and start running a safer, more profitable practice, here's the next step. First, book a strategy call with us, Practice Performance Partners. We'll uncover the biggest risks and opportunities in your practice. Then, choose the package that fits your goals. From there, we'll get you launched with confidence, with clear systems, with expert support, and with peace of mind, knowing your practice is protected and set up to grow. Don't wait until something goes wrong. Book your strategy call with us, Practice Performance Partners, today. Yeah, well, there's these kind of interpretations of what might be normal. So, for example, they might say, well, they might have heard that something's only going to get paid one time a year, right? So maybe the OCT gets paid one time a year or twice a year, and then they assume that like they shouldn't ever do the OCT again if there's uncertainty, or they extrapolate that getting paid for an OCT to getting paid for a field. So now they think, well, I'm only going to get paid one time a year. They hear it somewhere for an OCT once a year. Now they think, well, I'm only going to get paid one time a year for a field. And so then they stop doing repeated fields, or they might not do a 10-2. If they've got, let's say you've got moderate glaucoma and you're concerned about getting close to fixation, where you switch the threshold over to severe glaucoma. So then they're worried about doing a 10-2 to differentiate between moderate and severe glaucoma. When all you really have to do is be able to document in the clinical record that you're concerned about that being within the, and that may make you within the 5 degrees of fixation, which would make that patient more at risk for central vision threatening, and you might make additional treatment recommendations because of that. So, but you have to build that in the chart. So I guess my point is that on the one hand, you get complacent because you might say, well, they're only going to do it once a year, so I'm only going to do it once a year. Also, you'll get complacent with not actually telling the nuance and complexity of that specific patient of, well, I really had to do four visual fields for this moderate patient this year because I'm trying to determine if they are converting into severe. So I'm having to do 24-2s, but I'm also having to do 10-2s, right? That's what you're talking about as far as complacency is, that documentation complacency can go both ways, right? I can be lax.
I think from a complacency standpoint, what I don't want people to do is just assume that because a patient has a certain ICD-10 code that we treat them all the same. Everybody's individual in how they respond to their medications. Everything that goes on with them is individualized. What we start with is a foundation, and then we adapt the care to the individual as appropriate. The medical record is always going to dictate what we do, right? Because we don't invent the symptoms, we don't invent the findings. Our job is to test and interpret, and then use our clinical knowledge to take that interpretation and effectively manage that patient's care and therefore their outcome. The fallacy that you bring up, and I say that in people assuming that if I'm only going to get one visual field paid for, or one OCT paid for. I don't know where that comes from, right? I mean, it drives me crazy because I see it in day-to-day conversations with clients of ours. The beauty about the United States healthcare system is that a physician will always get paid 100% of the time for 100% of what they do. And we forget that sometimes. What you meant to say was, right, if I can paraphrase it, is that...
No, please do, yeah.
You have payment assistance for one of the visual fields that you're going to get in that calendar year. That comes from the insurance carrier, right? But if the patient requires additional visual fields, then those need to be ordered, or I should say recommended, ordered, and performed. If the patient says, I don't want to pay for it because at that point in time, I'm going to have to present them with an ABN that explains the reason why I think this test is important and why I believe that their insurance or their payment assistance program may deny it. And now I can have that conversation. I can say, hey, Mrs. Smith, it's very important that we have this test. Your carrier only allows for one of these in a given calendar year. However, I feel it's extremely important because it's going to help me determine how fast your disease is changing and how that's affecting your sight and what our next treatment step needs to be. That begins that conversation. I don't think I've ever met a patient who's going to say, $135 is the difference, that's the price I'm going to put on losing my eyesight. And I can fight that with my carrier if I need to. And that's the purpose of an ABN, is to force that conversation so the doctor can explain to the patient why this is important and also explain to them the limitations of their healthcare coverage. Because healthcare is not designed to cover everything that's wrong with us. It's there to help offset some of the costs that people incur in a given year. I mean, we know that. You and I have both seen over the years, even if I took the last 5 years, deductibles have slowly crept up, from an average of about $5,500 per year per individual to now over $7,000 per year per individual. Yeah. And so, that's just the reality of that marketplace. We can't control that. The patient can't control that. It's often those decisions are not even in their wheelhouse most of the time because their employer is buying the healthcare coverage that they have. We both have to follow the parameters and the contracts, of course, but that doesn't mean you're not getting paid for doing a test that you feel is absolutely, necessary to help that patient get the best outcome.
Do you think, that it's where do you think the bigger problem lies with this specifically? Are people running too many tests for glaucoma? Is it optometrists? Is it ophthalmologists? Is it glaucoma specialists? Who do you think is at the biggest risk when in your experience, when people call you in for audit defense? What do you see?
Personally, I think optometry overtests. I think all of you look up the CERT statistics with Medicare. That's CERT, C-E-R-T.
Yep.
Comprehensive
Comprehensive
testing.
area. Yep.
Yeah. And if you look at that, it's mostly optometry that's offending it. I think that optometrists use clinical testing to back up what they already know up here. I think it's one of those things that just gives them a little extra comfort. But if we had to say from an absolute medical necessity basis, what is it absolutely required to do? Maybe some would miss that. Maybe somebody would make that threshold. I think that glaucoma specialists, they don't do that so much. I think they rely more on their clinical understanding of what's going on. I think that they do less testing in less areas. I think they tend to focus on OCTs and visual fields more than some of the other, CPT codes that have come along to help us identify and manage a glaucoma patient. They don't do every test under the sun. I think many of them, based on their comfort level, do what they feel is necessary to manage the patient. And in fact, Chris, if you look at the preferred practice patterns, as you well know, or the AOA clinical practice guidelines, they're pretty basic, right? They talk about fundus imaging, they talk about OCT, and they talk about visual fields. There's not a whole lot of everything else out there under the sun, right? They stick to those foundational tests to really manage a glaucoma patient. And I'm not saying that the other tests aren't good or they're not important, but in relationship to the question that you're asking, I do think that optometrists tend to test more than an ophthalmologist, a general practitioner, and or a glaucoma specialist.
Yeah, and I think from a standpoint of some of these other tests that are what I'll call ancillary, right? Not really well borne out in, to your point, okay, we've got gonio, we've got visual fields, we've got OCTs, like that's your bread and butter. If it's outside of that clinical practice guideline, you've got to make sure you're establishing, because as you said, I think to kind of wrap all of this up from the start to the finish of this episode would be, as you said at the beginning, you're not just that's going to be your base. That's where you're going to follow. But if you want to do other tests, right? Let's say it's a color vision test, right? That might be actually really valuable, right? You might have a lot of value in that. But you just want to make sure that you want to have, when you order that test, what are you trying to gain from it? Are you trying to understand more about this patient's visual dysfunction, maybe their quality of life or their ability to be mobile in different scenarios? Totally legitimate, right? But you got to put that in the chart, and then you got to say how that test helped you advise the patient or change treatments or whatever else, right?
Well, I believe that if the doctor goes through the exercise and makes it a habit when they're ordering the test, whatever it may be, if they can tell the record what they want to do, why it's important to do, and when it needs to be done. If they can answer those three questions in the medical record, it will force them, right, to show that this is why it's necessary. Because if they can't answer the why, right, that's the most important part. If they can't answer the why with a straight face and say, this is where this clinical piece, like color vision for your example, it's necessary in this case because of this. So I have to use an anomaliscope to be able to do that. Or if I'm doing something with dark adaptation, I have to be able to justify this is what's happening and this is why I'm investigating this. The clinical tests that we do are designed to help us provide better outcomes for patients. They're not there just as a revenue source for the practice, right? It's all about the care that we give. And the one thing that you and I discuss all the time in our side conversations is, how do we get people to always practice at the highest level of their clinical license, right? Use every bit of their brain, their intelligence, their experience, their expertise to deliver a better outcome to Mr. and Mrs. Smith that they've been taking care of for a while, right? And I think if we start with the foundational things, right, and we start to individualize the care, and we provide the care when it's necessary, and we do the required elements, even if it's outside of the scope of what the foundation is, for that particular case, this was the right test at the right time for this specific reason. Those cases are the easiest ones for me to defend, because I'm not trying to second guess what the practitioner was doing when there's nothing in the record at all. And that's where we find most people fall flat on their face in an audit defense, is that there's not even an order written. It's just the output of the test. It could be a printout of the visual fields with somebody's initial on it. I don't know what that means. There's no interpretation. There's no individualization of that test. It's not even said why it was ordered. So I can't defend something like that in an audit because it's just absence of information. So the more you put, the better explicit that it is, the better, more consistent that it is from record to record. If you can just, as one of our members here, if you can make sure you're going to your record and saying, look, I want to create a pattern so it's very easy for anybody in my practice. Why did the doctor do the test? When did it need to be done? And what was ordered? I think those are just some basics that we can really employ in a practice to reach, that perfect blend of keeping my practice safe, but also being profitable in providing the best care. And I hate to say that in that way, but if you look at incidence and prevalence studies, and if you're just following that, I know offices are going to make more money than they're making now by providing standardized, well-documented, well-founded, clinical protocols. It just follows on itself. If you don't put the focus on the money, but you put it on the care, the money's going to come anyways.
Totally agree. So I would say, for the listeners, first is if you're uncertain about, maybe you've gotten a letter from your Medicare administrative contractor that says, hey, you're overcoding in some area, or you get a request for records and it all of a sudden makes you feel uncomfortable, then my advice first of all would be get a chart audit. Start with a medical records chart audit. We have that in Practice Performance Partners. We'll give you guidance on where we think that you could improve your documentation, where we think that certain things might fit, right? If there's ideas of like, hey, you're never ordering this test, why is that? We can give you those ideas. And then secondly, if you're a Practice Performance Partner Pro member, you have access to Comprehensive Optometry Simplified, which is a way to take clinical practice guidelines, preferred practice patterns, and customize them for your practice. Please reach out to us. We'll put some links in the show notes, and we'll see you guys on the next month.
Great. Thank you. Appreciate it.
Thanks, John.